videos on?
Good evening, everyone. Welcome tonight to our presentation. My name is Allison Elsner. I'm the Executive Director for the San Bernardino County Medical Society. And we thank you for joining us for our third in the series of COVID Treatment 2021. Tonight's session is titled Post-COVID Syndrome, the Next Pandemic. And we just want to remind everyone, if you don't mind, to go ahead and put yourself on mute. Thank you so much. So tonight's installment in this comprehensive series on our COVID-19 virus issues, we'll look at in-depth issues with the newest presenting problem related to COVID-19, which has several names: chronic COVID, also known as post-COVID syndrome, or you may know it as long hauler syndrome. It has multiple names, but it also has multiple ramifications and manifestations. And individuals are having chronic complaints involving every system of the body, including pulmonary and rheumatologic, dermatologic, and multisystemic. So we're going to hear tonight from Eric Hansen, DO, FAA, FP, whose family practice with Choice Medical Group in Hesperia, California. And as we know, Dr. Hansen developed this series, so he will be leading the discussion. And then we have our special guest expert and panelist, Roger Schwelt, MD, pulmonologist with Beaver Medical Group, who practices in Banning, California. So I'm going to go ahead and introduce both of our speakers tonight. As I just mentioned, Eric Hansen, DO, FAA, FP, established his own family practice in 2002 and is a board certified ABFM primary care physician. He graduated from the Western University of Health Sciences College of Osteopathic Medicine of the Pacific in 1999, where he is also a clinical faculty preceptor. Dr. Hansen currently serves as the trustee for the CMA Solo and Small Group Practice Forum. He serves as a frequent presenter on how to establish a successful telehealth practice, and he's a member of the California Medical Association's COVID-19 Task Force and Healthcare Advisory Technical Advisory Committee. He is a past president of SBCMS and was awarded Best of the Desert in the General Practice Physician category for 7 consecutive years. He is exclusively affiliated with Choice Medical Group and Choice Physicians Network. Thank you, Dr. Hansen, for all your work in this area and for bringing us this wonderful series.
Thanks, Allison.
Roger Schwelt, MD, pulmonologist with Beaver Medical Group in Banning, California, who, as we mentioned, will be our expert panelist this evening. Dr. Schwelt, the Associate Clinical Professor at UC Riverside School of Medicine and at School of Medicine and Allied Health at Loma Linda University School of Medicine. In addition to being a preceptor for PA and medical students, he was the medical director for the Physician Assistant Sciences program at Loma Linda University School of Medicine, for a sleep lab in the area, and for the Crafton Hills College Respiratory Care Program. He currently practices with Beaver Medical Group in Banning, where he's a pulmonologist and sleep physician. He is certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine through the American Board of Internal Medicine. Dr. Schwelt is also the host and co-founder of MedCram, a popular online medical video series. So we're going to turn it over to Dr. Hansen, and I just want to mention that after our presentation, we will be taking some questions probably on our chat room, and I think Dr. Hansen will be facilitating some questions and answers throughout the presentation. So I will turn that over and let Dr. Hansen figure out how he best wants to do that. And welcome, Dr. Hansen.
Thank you very much, Allison. And thank you again, Dr. Schwelt, for joining us tonight to discuss yet another important aspect to our COVID-19 pandemic that we have been dealing with for now just a little over a year. First, I'd like to just say another thank you to the San Bernardino County Medical Society, to the executive committee, and especially to the staff there for all your support with setting these webinars up, because without your help, we wouldn't be given the opportunity or have the platform to reach out to physicians and patients alike to really try to share information as we get it. And so thanks again to you guys. As Allison mentioned tonight, the subject is going to be very focused. So this probably won't be as long a presentation as we've done in the first and second segments of our webinar series. This is going to be basically focusing primarily on what we are calling post-COVID syndrome, or like Allison said, there's multiple names: long hauler syndrome, long COVID, chronic COVID, or most recently, post-acute sequela of COVID-19, or PASC. PASC. So for tonight's presentation, for simplicity, I'll probably call it PASC or chronic COVID, just so you guys all know what we're talking about. Before we get into the meat and potatoes of the presentation, generally, we've been doing a little bit of an update on treatment options, because as many of you know that are in the clinical world as physicians and others, we've had a difficult time with COVID cases as they've presented. And so for treatment options that are working and maybe not officially approved, but for things that can really help to mitigate the severity of COVID-19 infections and hospitalization, I urge you to go back to our previous presentations, and you can get more detailed information. But as a follow-up on that, I wanted to ask Dr. Schwelt one thing about treatment before we get into the post-COVID syndrome thing. And so right now, I know that there's been some new advancements, and one drug in particular called molnupiravir, and this drug is apparently showing early treatment of SARS-CoV-2 infections, showing complete suppression of virus transmission within 24 hours. And so do you have any other information on that drug being studied more, or any other input?
Can you hear me okay?
Yes.
Okay, great. Yes, so thank you so much, Dr. Hansen, for having me on again. So molnupiravir is novel in the fact that it is an oral medication. So up to this point, we've used monoclonal antibodies, we've used remdesivir. These are all infusions or intravenous. What's nice about this medication, and it's been studied for some time, actually first looked at in the 2000s for SARS and MERS. It's an oral medication. It targets the RNA-dependent RNA polymerase that helps the virus replicate. So in that sense, it's very similar to the mechanism of remdesivir, but it is an oral medication. There was a recent study that was published where they took 73 patients. They were outpatients. They had symptoms within 7 days. And what they looked at was within 5 days, they looked to see how many of the patients in the intervention arm versus the placebo arm were still positive for the virus on PCR. In the intervention arm, it was 0%. Nobody tested positive within 5 days. It basically just shut down viral replication, like you mentioned. Uh-huh. In the placebo arm, it was 24%. And so certainly very encouraging. In animal studies, it showed that this actually reduced transmission. So this may be a nice post-exposure type of medication, a medication like we use for the flu with Tamiflu. It has not yet been FDA approved yet for this, but it's certainly within the pipeline, and it's something that might be available to us hopefully within the next few months to a year.
Wow. Yeah, and that's amazing. And especially because the fact is, I mean, we're getting a lot of information about, the variants coming out, especially the UK variant, and potentially having, a little bit of some reduction in efficacy of vaccinations, yet they still are showing the efficacy that they do work, and potentially, reducing those hospitalizations. But there's still concerns, I know, about that. So we, and just in light of what's happening in Canada right now with their situation, and also what we've seen in Minnesota and even in New York, there may be concerns that we're going to have, more issues with other waves coming. And so hopefully we can get enough vaccinations done, and hopefully the vaccines stay effective. But this drug is at least some hope for the future. But I wondered, as far as, the timeline where things were. And so you answered that question. So hopefully we can get things maybe sped up on that, but that is at least some promise for the future.
Yep.
Yeah. All right. Well, thank you very much. And so now we'll get into the whole subject, like I was talking about, the post-COVID syndrome. And the reason that I felt that this was important to bring up is because since the onset of the pandemic a year ago, even maybe Looks like I'm getting feedback there. Okay, even several months into seeing the patients present approximately a year ago, it was becoming obvious that after these patients were testing negative for COVID, so after their acute phase from exposure to illness of approximately that 2 weeks, and then they recover or seem to recover and get a negative test result, you would, in early on in the pandemic, we were expecting these people would just recover like you do from most other viral illnesses, and you would not have any other trouble. But unfortunately, what I've seen, what multiple other clinicians have seen, is that we are seeing people being affected pretty much in every system of the body, and with some of the primary systems being pulmonary. So you've got people that have continued respiratory symptoms even up to 6 months and more after having their initial COVID infection. Also cardiac and rheumatologic. Many people have continued and severe joint pains for even months after, and dermatologic. People are manifesting rashes. And so those are kind of the top of that list. And I'll get into more details on that, but I wanted to ask you, Dr. Schweld, in your clinical experience, now that we're a year into this and being a pulmonologist, have you started to see some of that trickle down effect?
Yeah, so yeah, people are being referred to me because of continued shortness of breath, primarily, obviously, since I'm a pulmonologist. But also we're seeing issues with loss of taste, smell, olfaction, all sorts of things that are creeping along. The most common, of course, is just fatigue and inability to, do what they normally would do in the past, aches and pains. So all sorts of these post-viral things that we are now starting to see.
Right. And that's atypical, really, compared to other things. Like, we don't expect necessarily that after someone has influenza, for instance, we usually see a fairly good recovery. And I would suspect that you probably see the same, because it's not like you probably get too many referrals to you for post-influenza problem. I mean, I would imagine you generally, if they do need supportive therapy for a couple of weeks, that might be expected, but nothing like this before that I can think of.
That's correct. We don't typically see that. And I think it has to do with the difference here is that we see a lot more blood clots, and those blood clots can be in many different parts of the body. And depending on what organ they're affecting, they'll have different symptoms.
Right. And so that'll kind of get into our discussion on etiology. And so what I probably should do, because I was getting a little ahead of myself, but I was kind of justifying why we needed to do this talk tonight, but I'll throw out a few statistics here. So this is just so people kind of have a perspective on what's happened in the last year. Basically, we're at about 130 million COVID-19 infection cases worldwide to date. With those, about 31.2 million of them were in the US at this point. And this is the latest data, and you may find something different out there, but this is what I've found. Of the worldwide cases, 2.95 million deaths occurred. As far as in the US, out of that 31.2 million confirmed cases, we had 562,000 deaths roughly. Out of that number, we had approximately 300 of those being pediatric cases. And so there was another issue I wanted to kind of talk about briefly on the pediatric thing, but I'll move on and then we can come back to that. So it just gives you kind of a perspective. We got over 500,000 deaths of COVID in the last year. So that gives you some perspective compared to, say, influenza, where the worst years are just a fraction of those numbers. And so we obviously are dealing with a much more serious thing. And so for those that say, oh, it's not a problem, this is, the flu is just as bad, this is obviously, these statistics tell us otherwise. Would you agree?
Oh yeah, certainly.
Yeah. And so the one thing that I wanted to bring up, because we were kind of talking a little bit about vaccinations there and what, coming treatment wise in those. Now, we had some recent announcements made regarding the COVID vaccine being initially safe for 16 and over, and now that's been recently changed to 12 years old and older, with now a new, at least in California, drive to vaccinate children. Now, when we have statistics where we have 300 deaths from this in 1 year period, that becomes a little difficult when you've got a population of maybe, say, the 40-year-olds to above 65 accounting for the vast majority of complications, of cases, of deaths for sure. So I wanted to get your opinion on this because this is kind of controversial. You know, you've got multiple political, influences, you've got a lot of factors here, but if you look at the data alone, what is your perspective on vaccinating children for COVID? And I know we're kind of off subject, but I wanted to touch on it real quick before we get into the other.
It's a little, first of all, those studies are still underway, and we are waiting for the trials in Moderna and Pfizer, which are of course 16 and over, and I think Moderna and the Johnson & Johnson vaccine was 18 and over. What we have now in the United States, the vast majority of cases are of the UK variant. It's taken over quite a bit, and we're seeing takeoffs in Michigan. In Michigan, for instance, where we did a lot of vaccination in the elderly population, that seems to be successful now because the majority of the cases in the hospital, 50% of them are people under the age of 40 or 50 years of age. And so we used to think that children were not the ones that were spreading it the most. We now know that that's not the case. They spread it just as well as anybody else does. And we know that this UK variant is maybe 20 to 30% more infectious. So if we open things up and we've completely vaccinated the older population that is at risk for these complications, what you're going to start to see is what we're already seeing in Michigan, which is still a lot of people coming to the hospital because now it's spreading more rapidly in the environment. And you're going to see younger people, some without comorbidities, that are ending up in the hospital. When I say younger people, I'm talking about 20, 30, 40-year-olds.
Right.
So when we're talking about children, you've got to understand, of course, that these are the people that spread the virus on to the adults, right? It's not for their particular benefit in terms of mortality that they're getting vaccinated. It has to do with herd immunity. You know, a number of years ago, back in 2000, there was you all remember there was the pneumonia vaccine that came out, the conjugated pneumonia vaccine. It was Prevnar 7 at the time. It's now Prevnar 13. And it was first indicated only for children. And what we noticed after we started vaccinating children with Prevnar 13, which of course is a conjugate vaccine against pneumonia, is not only did we start to see deaths from streptococcal pneumonia in children going down, but we started to see deaths from streptococcal pneumonia in adults, in elderly, start to go down. And it sort of confirmed what we already knew, which was it was the grandkids that were killing off the grandparents with streptococcal pneumonia. It's not a very happy thought, but that would be one of the reasons for it. The other reason, of course, would be that there are complications, right? There are complications that can occur with COVID-19 in children. So that's another possibility as well. So there are arguments to be made in terms of children being vaccinated theoretically, philosophically. What we need to do is look at the risks and benefits when the trials come out and see what the risks are and how well they work in children.
Yeah. All right. Well, thank you for that, because that was just an interesting aspect that really has just only in the last week or so even become a topic of discussion. And so it's important that we do consider that data and that we look at the big picture and not only the one aspect. So great information on that. So really getting to the post-COVID syndrome, the important thing to remember, like you had mentioned, is that there's a great variability in the recovery phase on COVID-19, basically, that we see neurologic, cardiac, GI, musculoskeletal, pulmonary etiology or manifestations of this prolonged COVID situation, whatever you want to call it, this inflammation or whatever's happening here, with those systems being the primary ones, but multiple other systems being involved. And it's not necessarily tied to only hospitalized patients. We see it in not hospitalized patients and hospitalized patients. So it's not just like the very sick end up with post-COVID syndrome. You have some people that may have had very mild to moderate cases, but they still have symptoms 6 months later. Is that what you would see as well?
Yeah, so they can have symptoms up to weeks to months later. And we've had patients that were infected in early last year and still are having some of those symptoms.
Right. And to date, there really is no approved definition of PASC, the post-COVID sequelae syndromes, or the long hauler syndrome. And it's really more of an accumulation of symptomatology, I think, at this point, because no one's really put a number on it that you have to have 3 manifestations to qualify, or 1 manifestation, or that it has to go beyond 6 weeks, or any of that. So we still haven't really gotten a true definition. So for the physicians that are on this call saying, well, what do I call post-COVID syndrome? What would your answer be to that? Would it be someone that is tested negative that has continued symptoms, or someone that's gotten past 4 weeks, what would be considered that post-infectious phase or late phase that you would, I mean, like in your perspective, how would you define it?
Yeah, I think it's going to be based on timing. I don't think that we're going to be using testing as the definition for that. I mean, they may decide to do that if they do research, just to make sure that that is one of the criteria. But from a clinical criteria, if somebody continues to have symptoms, whether it's 3 or 4 weeks, I think they're going to have to come up with some sort of a definition on that. Yeah, generally speaking, they've moved away from needing testing to determine whether or not someone is post-COVID or not.
Right. And I think that what leads into that as well, and what we need to remember is that we can't entirely rely on the testing still. Even a year later, the false negative rate on the PCR testing is still got a lot to be desired, in my experience. Is that what you're still seeing as well?
Yeah, I mean, from the very beginning, we knew patients had COVID. They were in families with COVID. They had the signs of COVID. They looked like COVID, and they were testing negative multiple times.
Right. And I think that's a worry, because I know I have patients where they're calling with specific symptoms, and I'll tell them we need to take these precautions. We need to start you on this amount of zinc and vitamin D and do all the things we talked about in the previous talks. And many times they're reluctant because I think, one, they don't want to be labeled as having something for sure. And then also they'll come back and I'll get phone calls saying, see, I didn't have it. My test was negative. But yet they can't smell or taste. They've got a severe headache, they've got fever, and they've got cough. And it's like, oh my gosh, okay. But you know, that's just always been a struggle. So I imagine many of the physicians on this call are probably experiencing the same thing. And so it's just important that you remember that you treat the patient, you treat the symptoms, you don't rely on the tests entirely. And so that is important. There was some things that I did find on this post-COVID syndrome, that there were factors such as increased age, increased BMI, the female gender actually was even on the list, and having greater than 5 symptoms at the time of the acute phase could potentially, and did actually, when they considered the data, tend to lead to more long-term sequelae. So I don't know if you've had that experience in your practice too, that you had some people that had multiple symptoms, even if they weren't that sick, but those were the ones that potentially had more lasting shortness of breath, for instance, or the like.
Yeah, this rings true. Although I've had patients who have been on ventilators, and I just saw one last week who came in, and he looked great, even though he was on a ventilator for a couple of months.
Right.
But he was young.
Wow. Yeah. And so that's where we just see such a variation in the presentation, and you can't predict this virus. And that's, I think, another important aspect, that when people ask you, well, should I get the vaccine, doctor, you know, based on my health history? And it's like, well, I can tell you statistically that you're probably at increased risk, but I've got people that are sicker than you that got COVID and they were only sick for 2 days. And I've got people that were a lot less problems and they were dead in 3 days. And so you just can't predict it. And so I think that, you know, that's obviously something we all have to remember. There was another study that had been done that suggested that, well, there's been several basically, but there was one in Wuhan, China, that actually was done very early. It was January to June, basically, of 2020. So really early in the pandemic phase, and that they studied patients that in that 6-month interval, approximately 76% of those patients had at least one of their previous symptoms of either fatigue, muscle weakness, brain fog, neurologic symptoms. 6 months later, that was a really high population at that point. Further studies that I found, they were suggesting more along the lines of about 30% at potentially up to 6 months had specifically neurologic findings, like you had pointed out earlier, of lack of smell and taste still, and fatigue and brain fog. And so has that kind of been your experience as well?
Yes, and there has been some studies that showed that 1 in 3 would go on to have neuropsychological or neurological conditions. I don't know if that was all people with PCR positive or if that was just in the hospital, but that seems like a pretty high number.
Yeah, so that basically, reinforced the need to have this discussion, because that's a lot of folks that are further out than you would expect to have continued symptoms. But the problem is that they're coming to you, they're coming to me, they're coming to the other physicians on this call, and they're saying, "Doctor, help me. I can't smell anything. Everything smells like straw, or everything smells like I don't know what, or I can't smell it at all. Or I can't lift my arms above my head." In some cases, people developing what seemed like seronegative rheumatoid arthritis 8 months ago and still having problems where they never had any issue before, and now they have severe synovitis, and all these, lasting sequela. So the problem is what do you do with these folks? And I think, I could go on and on about statistics and how many people are having continued problems, such as difficulty sleeping, hair loss, lack of taste, trouble with mobility, all these things. The point is there's a large number of folks. And so that was where we needed to kind of have a discussion, look at this data, but then brainstorm as well about where do we go from here and what can we do now, rather than telling people maybe in a year we'll have an answer for you, or here's a number for a support group. So I was curious to get some information from you about what are you doing with your patients? And it might be important for us to maybe talk about what the causes are, but I didn't know if you want to talk about what you're doing treatment wise or the causes first.
We can talk about causes. Since we're bringing it up at this point, I've had a dental friend of mine who's been using essential oils essentially to try to wake up, if you will, the olfactory sense. So she's had about 3 or 4 of her patients that have come in that have not been able to smell, and they've tried to retrain their senses with eucalyptus oil, for instance. And out of those 3 or 4 patients, all of them within a week of using the essential oils were able to start to olfact again. Olfactory sensation started to come back. Don't know whether that was a coincidence or whether that was related to that. So something I'd just like to pass along.
Yeah, so that's interesting. So we can get into that a little bit more then. So we'll go ahead and talk about, because I had it kind of on the agenda that I didn't need to throw you a curveball, but ideas on etiology or cause. It's basically, there's a lot of thought out there. And one that was interesting that I heard just later or earlier this week was the possibility of viral protein persistence. And that suggests that you don't have an active virus still present, but you've got components of that virus potentially still floating around in your body. So what are your thoughts on that as a possible cause or etiology of continued inflammatory or immune response to what your body thinks is maybe a chronic COVID infection when the virus function itself has been diminished?
Yeah, so in addition to chronic blood clots, I think that is also a very prevalent thought. As you know, the virus has about 25 to 28 different proteins in it, and it's replicating millions and billions of times in the body. And so it seems a little bit naive to think that every single remnant of that virus is going to be cleaned up immediately. It also kind of lends some credence in terms of what we'll talk about later in terms of the interesting effect of vaccines.
Right. I know that was one thing I was going to bring up. And so, I think one common thread that I have seen in the patients, no matter what their presenting symptom is, if it's joint pain and swelling, or if it's neurologic issues, or if it's respiratory, or if it's dermatologic, there seems to be a significant inflammatory response that's a common thread throughout. And that kind of gets into how do you actually maybe work this up or evaluate it or measure these things? And we will talk about that next. But I wanted your opinion on that, because do you agree that it seems as if we're talking about a chronic inflammatory, either immune mediated or not, inflammatory condition?
Well, it certainly is in the acute phase. And so when the patient starts to ramp down, it stands to reason that inflammatory process is going to linger on and may taper down over some period of time That may be the reason why they're feeling fatigued. That may be the reason why they have some of these symptoms that they have that we're seeing. Certainly it could be the reason why they can't smell, because of the inflammation around the olfactory nerves. So it's certainly possible. There's been some look at that in terms of inflammatory markers like fibrinogen and CRP.
Right. And the C-reactive protein, we can talk about that because obviously it's a non-specific marker, just like SED rate or ANA. And for the lay public on the webinar tonight, these are basically blood tests that measure levels of inflammation in one way or another. And so what we're seeing and tending to see is that there is definitely a common thread of elevated inflammatory markers. And just like I'd mentioned about the one patient that has what appears to be seronegative rheumatoid arthritis following potential COVID infection, that would fall into that line. Now, there was one thing I was thinking, though, when I was kind of trying to put this together in my own mind. We see in the past, in previous cases, where you can have a child that can have a viral infection where the virus then can mimic in a way, in some cases, like when we have pyelonephritis that's caused by a post-acute phase of a viral infection. So basically you have I didn't mean pyelonephritis, but nephropathy, I should say, inflammatory nephropathy, where you'll have a child that can go into kidney failure after a viral infection because some of the tissues in the kidney appears similar to the virus, and your body's immune system then can kill your kidney. Now, is it possible that we can get a similar crossover effect, and not necessarily that we have protein persistence per se, but that our immune system has been activated and this virus has potentially mimicked something else in your body where you have continued marked inflammatory and immune response to that one thing? So for those people that have just joint pain, but their heart and lungs are fine, or they have one other organ affected, but everything else is fine, that doesn't necessarily tell us that it's just a systemic inflammatory reaction, or you would expect that everything would have an inflammatory reaction. So do you have a thought on that? I wasn't clear about my explanation, but hopefully you got that.
Yeah, no, absolutely. So post-streptococcal glomerulonephritis, rheumatic heart disease, Guillain-Barré syndrome, these are all conditions with well-known triggers prior to that, either viral infections or bacterial infections, where the immune system makes antibodies against these foreign substances, and then they cross-react and they cause all sorts of problems. So a lot of autoimmune conditions are felt to start that way, and certainly no question that can happen with this type of viral infection as well.
Yeah, and if that is the case, that's going to lead us to what do we do about treatment? Because many times when we're talking about the triggering of an autoimmune disorder, that is not an easy thing to turn off. And so we can talk about that more in a minute, but that was kind of one of the things that was on my list. The other is that organ damage, and you brought up about blood clots, because that's obviously a thing that I think, is happening out there that's harder to find, and that physicians may be missing things. And so do you want to talk a bit more about that, end organ damage from blood clots, if you don't mind?
Yeah, so blood clots can basically go anywhere there's blood vessels. So that can be the brain, that would be a stroke. That could go to the heart, that would be a heart attack, obviously. But it could also go to the kidneys, and you could cause problems in the kidneys or in the bowel, and cause inflammatory bowel things there as well. And so so long as those blood clots are there, they're going to cause problems. When they looked at the autopsy reports, this was published in the New England Journal of Medicine last year, 9 times the amount of blood clots in COVID autopsies versus, basically standard autopsies where there was not COVID-19 or lung disease. So certainly that is a possibility. And I've had a number of patients in my own practice where I would routinely check D-dimer levels. A D-dimer is a blood test that checks for the end products of coagulation. And so if it's elevated, it's suggestive that there could be blood clots, but other things can also raise the D-dimer as well. So it's not very sensitive. It's not very specific. It's actually quite sensitive. Anyhow, the issue being is I've noticed that a number of people with blood clots now that had COVID previously. So it's certainly something to watch for.
Right. And I know we have a lot of comments in the chat basically about the potential for the use of, well, one, anti-inflammatories and immune modulators. And so we'll get into that again here in a moment, but about specifically anticoagulation. So the use of aspirin and the like, are you routinely putting patients, pulmonary patients, on aspirin until you can rule out if there is blood clots at the cause of their continued pulmonary symptoms?
No, so there has been a lot of study on this, and there was a very, very large, in fact, 3 consortiums got together to do very large studies on this topic, specifically in 3 different categories. The first category was, what about patients admitted to the intensive care unit? The answer there was no anticoagulation. It's more risk than benefit. Second group was those people being admitted to the hospital without the need for intensive care, so just regular acute care bed. The answer there was, yes, there's more benefit than risk, so do anticoagulation. And then, of course, the third one, which we're interested in here today, is outpatients. There was a recent study that was just published that showed that COVID-19 patients not requiring hospitalization did not benefit from empiric anticoagulation. Now, that may be talking about things like factor Xa inhibitors or direct thrombin inhibitors, things like Eliquis, Xarelto, and not so much aspirin. There's been another study that looked at the possibility that aspirin actually might be beneficial, but as we've talked about before, aspirin can also cause the shutdown of a fever, which is one of the major tools of your innate immune system, which is really important early on in the course. So I think the jury's out on aspirin, but certainly outpatient anticoagulation is a no.
Yeah, and that's a difficult thing, because I know there was a recent study that was published in eLife, and they were talking about the COVID-19 symptoms and the development of strokes and heart attacks weeks or months after recovery. And so we're talking about this vascular issue and potentially maybe an intravascular response as well. So have you heard anything about studying that specifically from the cytokine storm and in vasculitis and, like, COVID toes, for instance, and these things that we're seeing that specifically seem to be vascular?
So not definitive, and certainly not in these long hauler case, but what we have been looking at was the use of N-acetylcysteine, which is a disulfide bond ligator, basically cleaves the disulfide bonds. That's important because von Willebrand's factor, which is a subendothelial protein, is useful in the initiation of coagulation in the blood vessels. And the way they do that is with disulfide bonds. Of course, the thought there is that the ACE2 receptor on the endothelium is being activated. That causes the accumulation of inflammatory cells. That inflammation then causes there to be a inflammatory release of von Willebrand's factor, which then causes the thrombosis. It's interesting to note that because a lot of these clots that we talked about were not red clots or clots full of thrombin and fibrin, but rather platelets or white clots. And so the platelets and the von Willebrand factor are intimately related. And that may be what we're looking at there. But in terms of NAC, N-acetylcysteine, this is an over-the-counter supplement. It's also used to actually lyse blood clots. And some studies have shown that N-acetylcysteine can do that, in addition to the fact that it can also be an antioxidant, and it recharges the glutathione peroxidase system. So NAC was looking very promising. I haven't seen studies at this point yet on that issue.
And as far as the safety with NAC, I mean, if anybody wanted to take that supplement, are they going to hurt themselves? Is there any studies that show, like, where we've had vitamin D studies, for instance, where mega doses may be harmful? Do you have any feedback on that?
Well, there was a study that was done back in the 1990s that looked at 600 milligrams twice daily over a winter season to help prevent flu. And it did not turn out to prevent the flu, but it did reduce the severity of the flu in those patients that did contract it. And over a winter season means 3 to 4 months at a time. And there was no adverse reactions in that randomized placebo-controlled study.
Interesting. All right. Well, I know we're kind of getting into some treatments, so it's a good segue to just kind of touch one quick thing on workup, and then we can talk about the whole what is possible on treatment for the future, for now, what's safe that we can try. So we had mentioned about some of the inflammatory markers. Specifically from the pulmonologist point of view, do you monitor pulmonary function testing in your long haulers with the pulmonary manifestations? And if so, now that we're a year into this, have you had any that you've been able to follow even for at least a few months to compare to see if they progressively are improving, or where are you on that, on using PFTs?
Yeah, so for a while there, we weren't doing PFTs very routinely because of the fact of COVID. We didn't want to expose our respiratory therapists to that. And so we're just starting to get PFTs up. I have not gotten more than 1 or 2 of them. I would recommend getting PFTs in patients who are hospitalized and who were, for instance, on the ventilator and had ARDS. That's where I would go. I mean, to sort of take a back step about what I do in terms of workup. If a patient's been hospitalized, I typically like to see them back in the clinic within a week of discharge when we're talking about COVID. If they were an outpatient and they had comorbidities, then I think it's reasonable to see them back after 3 weeks or so and see how things are going. If it was mild disease and you're looking at them as an outpatient, I would only follow up with them on the basis of COVID-19 if there are persistent problems and things that are suggestive of COVID-19 long-term. Again, I don't believe that we have to retest for COVID at those follow-ups. I think a timing, waiting for enough time after the hospitalization is reasonable. Now, if we're looking at specific symptoms, and I'll put those in different categories, there's cardiopulmonary. Obviously, you want to do a workup that is specific in terms of history and physical for cardiopulmonary diseases. What a lot of people are recommending at this point is getting a repeat chest x-ray at 12 weeks. So that's about 3 months later if there was abnormalities on the chest x-rays previously, because it'll take some time for that to clear up. If things don't clear up, you're concerned about malignancy, consider a regular CAT scan. If you're concerned about interstitial lung disease, get a high resolution CAT scan. If there's intermittent cardiopulmonary symptoms that are suggestive of the heart, specifically ischemia, you would consider getting an EKG at that point. I would have a very low threshold for echocardiography because of platelets and clots, looking for pulmonary artery systolic pressure, but also for myocarditis and inflammation and pericarditis. So that's also something that I would do. I don't think you need to do it routinely, but if there are concerns that make you suspicious, I think getting an echocardiogram would be good. If the patient was in the hospital with ARDS and they had on the ventilator, then getting a pulmonary function test and a 6-minute walk test, I think would be reasonable. If things are just not getting better, if things are not forthcoming or you're scratching your head, I think I'll consider getting a referral to cardiology or pulmonary, depending on where the symptoms are coming from. So that's from a cardiopulmonary where I would go.
Yeah, and it's a little difficult in the outpatient setting sometimes because in a non-hospitalized patient that was able to have been managed as an outpatient, chest x-rays are not the first thing you're doing when you're sending an acute phase COVID patient, because they won't do the radiograph at the radiology location if they're actively ill. It's like you're either in the hospital or you're not. So many times we're having to pick these chest x-rays up months later when I have persistent patients that have continued shortness of breath and being winded with just mild exertion when they never had a problem before. And so that's a little difficult. And I know that in many of those patients, their chest x-ray will come back as a normal appearing chest x-ray. Rarely am I seeing that they now have developed maybe some scarring or interstitial lung disease that's being called on that chest x-ray. So that suggests to me, since we're talking pulmonary, that we're talking at that point more of an inflammatory. If you've ruled out the blood clots and the PEs and these major things, and they're not necessarily desatting, but they have persistent symptoms, it suggests like more of an inflammatory condition, potentially with bronchial spasming. It seems intuitively that may be what's happening. Do you agree with that, or what are your thoughts on that? Because I've been giving corticosteroid inhalers and getting some relief, but even some people that are continually using their inhaler a month or two, still having persistent symptoms.
I think it's all in the history and physical. If they've got swelling, then I would get a D-dimer and go from there. If it's a wheezing on a physical exam, then I think inhaled corticosteroids are a great idea. So let your history guide you, let your physical exam guide you, and then work on those things. And if they're not getting better, then cast a wider net.
Yeah. And, you know, we talked about the markers, and because they're non-specific, it really can sometimes be a bigger problem to have the results of an elevated ANA, a CRP, or ESR. What do you do with it, right? And so do you test folks that you're having, say, if we want to stick to pulmonary symptoms, they're having persistent symptoms, you're giving them the corticosteroid inhaler, you know, and they're not necessarily improving, and you've ruled out that they have, you know, any of these other vascular or blood vessel kind of issues, where are you going from there? Are you trying a short course of a oral steroid, for instance?
Yeah, again, on the history and physical, if they are having wheezing or if they're having shortness of breath from that standpoint, then I may try that. The other areas is, of course, getting a transesophageal echocardiogram, or sorry, a transthoracic echocardiogram to look for elevated PA pressures and myocarditis.
Yeah. And so along the lines of the other persistent symptoms, I mean, it's really been a challenge to try to figure out, okay, what do we do with folks? And so you oftentimes find yourself in a position where you have to think logically, okay, about these symptoms, what exactly are they presenting with? And it's almost like no two are alike, it seems, so far. A year into this, it's like everybody's got something different, or a different combination of multiple side effects. And so I've been trying not to use a trial of steroid because of the worry that potentially we are talking about a persistence of the virus itself.
Yeah.
But now it's seeming like it's really more, from what I'm seeing, intuitively thinking as a clinician, that I suspect that we're talking more about an inflammatory response, potentially due to a prolonged immune trigger. And it seems, from what I've seen, because a couple patients, especially like with the dermatologic manifestations, in trying a short course of a corticosteroid, they actually respond very quickly. And so that's interesting. And it's only been recent that I've actually gotten the guts to do that, you know, because of the fact that I didn't want to try and make some chronic COVID condition worse if it was a continuation of viral growth. So what are your, well, you kind of already said your thoughts on that, but do you have more to say about, you know, the idea of trying that?
Yeah, so I would probably put that lower in the algorithm, just because I wouldn't want to give steroids to somebody who doesn't need it. But again, let your history and physical be your guide. Sometimes it directs you to what things are sensible, because like you said, everyone's different.
Right. And the other thing that I expect is that even the people that I've given maybe a short Medrol course of, you know, 5 days, that potentially I expect in a month they're going to be calling me back because this may return, if it is autoimmune mediated. And so that's what I will continue to look out for. But along those lines, you had brought up something earlier about the potential for some of these long COVID symptoms being relieved. We're getting anecdotal stories being relieved by vaccination. And so I know I've had at least 2 or 3 patients that have called me that prior to that had about 6 months of post-COVID symptoms of multiple types. They got their first vaccine. 3 days later, all of a sudden they can smell again. And so you even mentioned the name.
Yeah, and there was a study recently that looked at this, where they took these patients that had COVID symptoms, long COVID symptoms, and they checked them out with the vaccination. And it was it was in this country, so it was with the Pfizer, BioNTech, and also the Moderna and the Johnson & Johnson at the time. There was a decrease in worsening symptoms in the vaccinated group. That was 5.6. So 5.6 versus 14.2. And then a decrease in symptom resolution. That was, an increase in symptom resolution. That was 23% in the vaccinated versus only 15 in the control group. So the vaccination, they think, may be just resetting the immune system, or it may be boosting the immune system to finally knock out that last bastion of viral particles that are hanging out somewhere in the body that are causing this ongoing symptom. I mean, there's some pretty dramatic stories that I've seen on the internet that have been in some news articles, where literally this lady was just sort of kicking along for 6 months, Then she finally got her vaccination, and then all of a sudden, immediately afterwards, she was at like back to 95% of normal. It was tremendous. But then there've been others where that hasn't happened.
Right. And that unfortunately begs the question, because that can steer us down two different complete paths. You've got one where you've got the idea that you've got continued viral growth. You got another one where you actually have your immune system that's been triggered. The virus is gone, but it's still going and you're resetting it. So that is two different pathways of where do we go with treatment. So unfortunately, we end up with a lot more questions than we do answers. Now, along those lines, there was actually a question I can just hit on real quick in the chat about how many weeks post-COVID can someone get the vaccine? I understand it's probably about 90 days. Is that still what you're hearing as well?
I am hearing that, but I'm also hearing that that they're trying to shorten that. And I don't know if that's official yet. They are not trying to shorten the idea that monoclonal antibody administration would be sped up. So if you had monoclonal antibodies, that would be the Regeneron or the Eli Lilly products, when you were tested and had positivity and you were part of a high-risk group, if you got these, they still want you to wait 90 days. I believe that's still the case after the COVID, but I'm hearing that they may be changing that or trying to shorten that.
Right. And that kind of went into the next thing, because the possibility of using monoclonal antibodies to treat chronic COVID or long haulers, that's also something that's being studied. Do you have any more information on that?
So they are looking at that. The only information that I've received so far is the bamlanivimab and a number of these other medications. They are actually looking at giving it as not an infusion, but as an injection under the skin. So what we call subcutaneous injections of these monoclonal antibodies.
Mm-hmm. Interesting. And then, one of your favorites too, zinc, utilization of zinc. I think it still continues to play a role. There's been some studies recently that suggest, that because of the need for zinc to maintain the health of cells, especially in the cardiovascular system, and lowering inflammation and oxidative stress, especially in the endothelium. So if we're talking about intravascular, that zinc still plays a role in that. Is that something that you agree with?
Certainly, I think zinc is a good thing. 40 milligrams daily, elemental. Anything more than 40 can cause copper deficiency. So just be aware of that. So you don't want to overdose on zinc.
Right, because I mean, in the 21 days, or you can even do 14 days, that's the time when you would do, according to our previous talks, those higher doses, but definitely after that, tapering back down is what you would advise as well, right?
Yes.
Now, talking about medications and treatment and what's been tried, I know up to this point, hydroxychloroquine, I know I've had anecdotal luck with using hydroxychloroquine, but only in early phase and in conjunction with zinc. In late phase, I've had basically no response. And I think that's consistent with the data on hydroxychloroquine as well. Do you agree with that, or do you have any more to add on that?
Yeah, I haven't seen hydroxychloroquine being tested in late COVID.
Yeah, and I've just, anecdotally, tried that on a few patients and really had no response. And so that was interesting, because I didn't have anything else I could do at that point. This was several months ago. And I at that point, after only a few patients really with no response and only a 7-day course, I went ahead and stopped that practice, only reserving it for those early acute phase patients that are having significant pulmonary symptoms, trying everything I can to keep them out of the hospital. In some cases, very dramatic results. And we talked about that on previous talks. The next thing I wanted to bring up, though, that really no one I don't think is studying yet, was the potential for immune modulator type drugs. Because if we're talking about an autoimmune trigger from this virus, and that the virus potentially isn't there anymore, but the immune system is running amok and going on its own and doing this for a year, 6 months, however long, is there a role potentially for drugs like methotrexate, for instance, to potentially turn that response down, in your opinion? Is it worth the risk? Because that drug obviously has multiple side effects.
Yeah, I would not be putting immunomodulators on post-COVID patients at this point without further guidance. Especially if there's any truth to the possibility that there's a reservoir of viral particles, there could be a rebirth of that, a reactivation of that virus.
Right. And that's been the thing that's kept me from using even the shortest course of corticosteroid, but yet it seems like people do respond. And so it's a catch-22. But I thought I would throw that one out there because there's been discussion about those types of medications. So the other is, because there does seem to be a common thread of inflammation, no matter what the cause, what about your ideas on other medications besides non-steroidal anti-inflammatories, drugs like colchicine or indomethacin? Have there been much study on that you're aware of?
No, I know they studied that for the acute phase, but not for long COVID. I suspect that there's a couple of phenotypes in these post-COVID patients. I believe that there's a subsection that have blood clots. I probably there's a subsection that has the virus is still hanging out and the immune system needs to kick it out. So in other words, it needs to be boosted. And there's probably a subsection, a phenotype of people that have their immune systems overworking and it needs to be tamped down a bit. And so because of those are mutually exclusive phenotypes in some cases here, you've got to make sure that you are finding out which one they fall into. And there may be some Venn diagram stuff going on where they're actually in multiple groups at the same time. So it's a difficult situation. I don't think it's a one size fits all. Your history and physical and your testing is going to have to ferret out which ones have the clots, which ones have the virus, and which ones have the high immunity. Once you figure that out, it'll be more obvious about which one of these you might want to try, including the non-steroidal anti-inflammatories.
Yeah, that's very insightful. And, really, it's like all of a sudden a bell went off, because just like anything else in medicine, there's never a black and white explanation. You have measures of gray all across. And I'm sure that that's most likely what we are dealing with, because we see such a variation in the presentation of the symptoms in these patients, and at different time intervals and at different severity. And so I think that you're probably onto something there. And I think that's something I actually have not heard or put together until this moment. And I think that that's important. I keep thinking about trying to find the solution to the problem, but really, if we have multiple problems, there's multiple solutions potentially. And I think there's some things we can do that are at least safe, preventative potentially. And I think we should maybe touch on those things and maybe kind of collate that for our audience. And I think that, we already kind of talked about the zinc. You talked about, what other supplemental, the essential oils potentially. Those are some things you're not going to harm yourself with. There was the other supplement, if you can remind me, I forgot to write it down here.
Well, there's in terms of prophylaxis, there's vitamin D, vitamin C, zinc, N-acetylcysteine, there's quercetin. And what I have been looking at specifically, and I think there bears this out, there's a lot of studies that have shown that the virus, when it first infects, suppresses the innate immune system, causes a reduction in the interferon response. So any way we can increase the interferon response, I think will be helpful. And one of the ways of doing that is increasing core body temperature. That's been known to increase the interferon response with viral stimulation. So hot, cold showers, sauna, spa, hydrotherapy, these sorts of things early on in the course of the disease, so that we prevent the virus from infecting a lot of cells and then therefore triggering the cytokine storm from the adaptive immune system.
Interesting. Yeah, that's really good advice, because all of those things you just said, we're basically talking about simple things that can be done. I know someone asked about omega-3 oil. I'm not sure if there's been much study on that.
Yeah, I'm not sure either. If anyone's interested in getting a little bit more of a practical instruction about how to do hydrotherapy, there's a couple of websites that I'll direct you to. One's called hydro4covid.com, hydro4covid.com. The other one is hydrotherapyathome.com or .org, one of those two. And those have some videos instructional about how to do that sort of thing. So if your patients come down with COVID, hopefully we don't have another surge, but if that were to be the case, those are things that you could actually just let your patients know about.
Right. And even along those lines, and I think even someone asked about turmeric, a general supplement that reduces inflammation. Do you advise on the use of turmeric or turmeric?
Again, it's benefit versus risk. I believe turmeric actually helps with endothelial function and also anticoagulation somewhat. So I don't see a lot of risk.
Right. That's what I've been advising my patients on, as well as the omega-3, because of that slight blood thinning ability as well, without inhibiting platelet function specifically. So I know we're getting close on time. We have about 10 more minutes, maybe a little less. The one thing I wanted to kind of talk about as well is, the question is, well, how long, doctor, should I expect this, right? And I don't know that we have an answer to that, but there's one thing, that we've seen with ARDS data, or acute respiratory distress syndrome patients. So in your experience with ARDS patients, I know some of them can have continued lingering symptoms for years, but if you used that as a benchmark, what would you anticipate?
I think that's a great benchmark, because this is exactly what these patients look like when they come out of the ICU. Not just ARDS, though. There's post-traumatic stress for being in the intensive care unit. If the patients were on steroids and steroids and paralytics, that's a setup for critical care myopathy. They could have weakness, and that needs to be evaluated with rehabilitation. So there's a lot of things that are specific to intensive care unit patients, regardless of what put them there, that can follow them for many years afterwards.
Right. And do you, even in those patients, though, see that at maybe several years down the line that they can reach, if not full recovery, they do at least get progressively better?
Yeah, there's hope that they can do that with the appropriate evaluation, the identification of these issues, and then a referral to the correct referrals, like pulmonary rehab, things of that nature.
And, I mean, really, we've touched on so much here. It's a lot of information, but to really kind of break this down, I think the things that we definitely need to be on the lookout as physicians is going to be the studies that are going to be potentially coming out to try to elucidate the immunological versus the chronic viral versus the inflammatory etiologies to this problem. And so hopefully, I know there's some study being done, but I think, we'll probably potentially have to come back and inform on what we do find out, probably months down the line. But in the meantime, we can post maybe some of these things that are simple interventions that the physicians can do now, because that's the important part. Why it was essential to actually even have this talk tonight is not just to talk about how bad the problem is, but also to what can you do tomorrow with your patient that comes in and says, doc, I'm having trouble. I can't even hardly move, or I'm really getting winded. I just take the trash out and I can't even make it anymore. What do you do? I'm taking your inhaler. What do I do? And I think that's the biggest thing that we need to be able to focus on. So you may have a list, I don't know, that you could provide to the SBCMS staff that we can post maybe on those supplements. I know we've got it in the chat as well.
Yeah, and or you could just type in MedCram update 59. It's also in there as well.
Perfect. That's even easier, so they can watch your presentations, because those are very insightful and very informative. So I urge anyone in the audience to check out Dr. Schweld's sites on MedCram related to COVID. And he's an amazing guy, because all his COVID stuff is free of charge. And so if it shows on there about paying the fee for anything related to COVID, that he's foregone that. So he's really amazing individual that you've done all that for the betterment of humanity. And I can't say it enough. But I think that we probably covered most of the questions in the chat, and I'll try and wrap this up. There was a person, does anyone check protein C and protein S levels? So have you yourself done that?
So if there's a hypercoagulable state and the patient's less than 55 years of age, we typically, if there's a clot and they're younger than 55, we do a hypercoagulable workup. And that will be part of that hypercoagulable workup, in addition to another bunch of other tests like prothrombin gene mutation 20210, factor V Leiden, antiphospholipid antibody, anticardiolipin antibody, antithrombin 3. These are just things off the top of my head that we typically check.
Yeah, and there was one other question I think we didn't get to, and it was, do you think obesity patients with full metabolic syndrome features are part of one of the phenotypes, the inflammatory and or hypercoagulability one? So is there a link that you think in your mind?
They certainly would be, yes. It's these patients that typically have oxidative stress, and typically these patients that develop blood clots as well. They may even be immunocompromised. So I don't know exactly which of those pools they would go into, but certainly the blood clots and that absolutely.
Okay, and there was, I think, one other question I missed somehow, but it said here, COVID virus targets the ACE receptors. ACE inhibitors may be beneficial, question mark?
Yeah, that's really interesting. You know, there was a study that was done very early on in the pandemic looking to see whether or not patients on ACE inhibitors or ARBs seem to do better, worse, or the same. And they looked at population studies. And what they found out was there was really no difference. So we don't know if these are helpful or not. But there's a lot of benefit that we know that ACE inhibitors do in heart disease, in hypertension, and all those. And I think that stands. But whether or not it has a role in COVID-19 and the long COVID, I don't know.
Yeah. All righty. Well, I think that we've pretty much exhausted this subject pretty well, and I really do appreciate your expertise. And like I said, you enlightened me on really a different way to look at this problem. And I thank you for that, because it's really going to affect how I work my patients up. And it's mostly, I'm not relying, unfortunately, on laboratory data because it's unreliable in many cases. But if you follow your instincts, you follow the physical exam, you follow those findings, you're going to hopefully steer yourself in the right direction. If you do need to focus in on specific things, like you need to get that echo, or you need to get the pulmonary function test, or you need to get the follow-up chest x-ray, you know. So I think the main take-home message is definitely to remember your teaching, to remember your insight and your experience. And that's what I would say. But any closing remarks, if you have any?
Well, I think there's two phases. There's the acute phase, which we are in, and hopefully we're exiting. And then there's going to be the chronic phase, and that's taking care of these patients for a long period of time. And I'm hoping that we're getting to that point. There are some signs that there is a slight increase in the COVID cases, whereas over at San Gorgonio, for instance, we had 0 or 1. This week we have about 4, and it's been holding at 4. So I'm hoping that with increased vaccinations, it stays that way. I think if we do have a wave that comes, it'll be much younger, and those patients perhaps without comorbidities, very similar to what's going on in Michigan right now. But as they go through this mill, basically, we're going to start to see more and more of them here in the outpatient. So we need to start learning how to take care of them. And I think presentations like this, Dr. Hansen, thank you very much for having these, are going to go a long way.
Yeah, well, I really appreciate you being a pivotal part in all 3 of our presentations. So we'll keep our ear to the ground here, and if there's new information to bring to all the physicians out there that we can reach out to, then we'll do it. You know, and I appreciate your participation in all of it, because you're a valuable resource. And I think the clinical perspective, you know, the studies that are being done are great, but many times we have to take that information, put it together, and actually make it adaptable to everyday life and what we do with our patients. And not always is it just the answer. Like you had pointed out, there's most likely going to be a spectrum of causes and effects and treatments. And so we have to remember that. But thank you again for your time, and thank you to SBCMS for putting this on. And I thank everyone for tuning in. And I think with that, we'll close. So thank you again. Have a great night, everybody, and stay safe out there.